morning, everyone. Next, we have talk on A to Z of uveitis. I am welcoming the chairperson, Dr. Dinesh Garg, and Dr. Subina Narang, co-chairperson, Professor Dr. Suprabhada Parida, convener, Dr. Anjana Kumari, Dr. Pradeep Kumar, and co-conveners, Dr. Nitin Mittal, and myself, the moderator. So the first talk will be on FFA and ICG in uveitis, Dr. Shweta Parak.
Good morning, everyone. Thank you for the opportunity to present. I will be presenting a case-based discussion on FFA and ICG in uveitis. So basic principles to remember are that retinal vessels are impermeable to leakage of fluorescein, and leakage shows that blood retinal barrier has been impaired. Choriocapillaris vessels allow free extrusion of both fluorescein and ICG molecules through large fenestration, which causes a choroidal background fluorescence, except in areas where inflammatory foci are present, making them appear dark or hypofluorescent. FFA is better for retinal pathology and ICG for choroidal. Coming to the cases, this was a case of peripheral retinal vasculitis in a 29-year-old male who presented with NVD, NVEs, CNP areas, and peripheral collaterals. This was the picture in the other eye. This was a case of syphilitic multifocal choroiditis in a young male who was TPHA VDRL positive with a very florid picture at presentation. And we could see different lesions in different stages of healing: perivascular staining, intense perivascular staining, disc staining, and lesion staining in the late stages, and multiple hypocyanescent spots in early, mid, and late phase of the ICG in both eyes. Patient was treated with topical steroids and benzathine penicillin and responded well to treatment. In this case, typical case of VKH with a typical OCT picture, we could see SRF, RP undulation and choroidal elevation, and early pinpoint leakage with late pooling of dye and disc staining in the later stages of the fluorescein angiogram, and multiple tiny hypocyanescent spots on ICGA. Patient was treated with immunosuppressants and steroids. This was a case of azure in a young male who presented with a normal-looking fundus and vision 6/6 and only complained of a scotoma, and he showed a typical trizonal pattern in both eyes, active in the right eye, healing in the left eye, and it was clearly evident on FFA and ICG as well. 3 months post-treatment, we could see normalization of the pattern and recovery of the scotoma. In this case of a 41-year-old female who presented with floaters and numerous creamy yellow placoid lesions at the posterior pole, we could see these lesions, which were hyperfluorescent on AF and presented with a bacillary layer detachment, and early block and late stain on the fluorescein, and numerous hypocyanescent spots on ICGA, which were more than were clinically evident. This was seen in both eyes. This was the case of APMPP, which responded well to treatment with steroids. This was a case of sarcoidosis with panuveitis in both eyes, snowballs, chororetinal inflammation, which showed intense staining in both eyes. And it responded well to treatment with immunosuppressants and oral steroids. And also, it showed extensive areas of scarring later on. This was a case of bilateral serpiginoid choroiditis in a young male who showed peripapillary hyperfluorescence and hypocyanescence on ICGA. After 3 doses of IVMP and under ATT cover and treatment with steroids, it showed recovery. However, later on, the patient developed an inflammatory CNVM, which was treated well and responded well to ranibizumab. This was a case of a young boy with Behçet's disease, turned out to be HLA-B51 positive, vitritis, disc edema, snowballs, snowbanking, and CME, and a typical ferning pattern on FFA. This was a rare case of bilateral diffuse uveal melanocytic proliferation in a 58-year-old male with a history of metastatic RCC, for which he had undergone radical nephrectomy, and the fundus picture was quite subtle. However, the fluorescein FFA showed a typical starry sky appearance, and a typical OCT picture with areas of RPE loss and thickening and mild choroidal elevation and a leopard spot pattern on autofluorescence. And patient was treated with Sutent. However, he progressed to develop exudative RD, refused to undergo surgery, and eventually developed NVG, and he still refused plasmapheresis till the end. He was put on palliative chemotherapy as well. In this case of toxoplasma chorioretinitis, we can see areas of scarring and with areas of adjacent inflammation and posterior KPs on the OCT. And we can see areas of retinochoroiditis on OCT, which is more of a retinal involvement than a choroidal involvement on OCT, and a headlight and fog appearance as well. This is the algorithm for interpretation of FFA in uveitis. It can show hypofluorescence or hyperfluorescence with blocked or filling defect on hypo, and hyper being leakage, staining, pooling, or window defects and abnormal vessels. ICGA can show intermediate and late hypofluorescence or early block and late stain, which suggests impaired choroidal ICG diffusion through partial thickness, stromal choroidal inflammatory lesions. This is the algorithm for interpretation of hyperfluorescence on ICGA. And in conclusion, FFA and autofluorescence are good tools for evaluation of inflammation, and we can use it as a follow-up parameter for superficial fundus structures. ICGA furnishes additional information on the choroidal compartment, which is otherwise undetectable. Several choroidal diseases present with the iceberg constellation, in which there are minimal signs on fundoscopy and more signs on FFA and ICG. Dual ICG and FFA should be performed for assessment and follow-up of posterior uveitis. However, in the latest armamentarium, OCTA cannot replace these two. Thank you so much.
Thank you, madam, for sharing your experience with different investigations.
Sorry, ma'am. I could not get that question.
I just told, thank you.
Thank you. Yes.
Dr. Shweta, in your practice, which one you are preferring more, FFA or ICGA?
So, ma'am, at our center, we look at it more of on an economical basis. For if we really need it and patient cannot afford it, we will do an academic ICGA. But wherever it is required, we will not skip it, especially for posterior uveitis. It yields a lot of information.
Okay. Can you tell me just one or two clinical points where you advise FFA or ICGA?
So, for more of chorioretinal involvement, and especially in cases with where vision is not corroborating with the OCT picture or not corroborating with the FFA findings, we will advise an ICGA also. Yes,
Do your treatment differ?
Yes, ma'am, definitely. It helps a lot, especially in cases of VKH and all where we are confused. ICGA will definitely show the hypofluorescent, like the iceberg constellation, hypocynoscent spots. And sometimes that really changes the diagnosis also.
Okay, thank you.
Yes, ma'am.
Any other questions? Okay, thank you.
Thank you.
Okay,
Dr. Vijay Pratap Singh
Okay,
for
fine.
his talk on viral uveitis.
So good morning, everybody. Thank you so much, AIOS, for giving me the opportunity in this academic feast. So there is a generalized notion that uveitis is either idiopathic or it's autoimmune in etiology, and it is going to be treated either by the means of topical steroids or oral steroids. But this is not true. So it was a case of 60-year-old female who presented with the diminution of vision in the right eye, and her best corrected visual acuity in the right eye was 6/18 and 12, and the IOP was 28 millimeter of mercury. On anterior segment evaluation, it was noted that KPs was there and flare 2+ and cells 2+ was present. So in the general OPD, the patient was treated with topical steroids and cycloplegics, but this patient turned up after 3 days with increased inflammation of cells 4+ and flare 4+. So the patient was referred to the department of uveitis. And when we evaluated, we found, is there anything missing? Yes. We revisited the case, and what we found that there was the history of fever 10 days before, and these KPs were not fine KPs. These KPs were actually stellate KPs, and there was sectoral iris atrophy at 6 o'clock position, and that IOP was again raised. So this was a telltale story of an infective etiology that is viral. So it was a case of herpetic uveitis, which was actually misdiagnosed as an idiopathic one. So these viruses not only presents with this, how we will investigate these patients? We investigated this patient, we did simply AC-TAP to prove that we were right. And on AC-TAP, what we found that this was a case of varicella zoster virus, which was detected on the PCR of aqueous. So these viruses doesn't manifest as anterior uveitis, they can also cause posterior uveitis, and particularly the group of Herpesviridae family. The most common presentation of Herpesviridae family that we see in our day-to-day clinical practice as a uvea consultant is acute retinal necrosis. This acute retinal necrosis usually presents with multiple or few discrete foci of retinal necrosis in the periphery, which rapidly spreads circumferentially in the absence of antiviral therapy with moderate to severe vitritis, and the most characteristic feature of ARN is occlusive retinal vasculitis predominantly involving arterioles, and this entity gives a typical Swiss cheese pattern. They can also present with hypotony. They can present with increased IOP. And the amount of inflammation in the vitreous as well as retina is intense. So because of this retinal inflammation, this retina is necrosed, there will be multiple tiny holes which gives it a typical sieve-like patterns. And while you are seeing a patient of ARN, there is unilateral involvement. Always have an eye on the other eye because this disease is having a tendency to involve both the eyes. Look for the prodromal features and the telltale sign of previous viral infection in the form of chickenpox vesicles or herpes zoster scars. The diagnosis is mainly clinical, but it can be confirmed by the means of PCR from the aqueous or vitreous. And if the Goldman-Whitmer coefficient is of more than 3, it is the diagnostic of ARN. Retinal biopsy is indicated in the cases of diagnostic dilemma. The disease mainly affects the immunocompetent people, and the most common cause of ARN is varicella zoster virus, followed by HSV, then CMV or EBV. Until unless you are not having the report of PCR, the initial therapy should be IV acyclovir in the dose of 15 milligram per kilogram body weight, but as soon as you are having the PCR reports, and if it is HSV, you should titrate the dose to 10 milligram per kilogram body weight per day for 2 weeks, and after that you will put the patient on the maintenance dose. You can go ahead with the oral acyclovir in the induction phase in the form of 1 gram TDS, and in later on you can go ahead with the 1 gram OD or BD depending upon the response to the drug. The role of systemic steroids is always controversial. If you want to give them after only 48 hours. Prophylactic laser barrage is indicated to prevent the retinal detachment, but that doesn't hold good. And if RD is there, surgery is indicated, but the results are really very poor. The other manifestation of Herpesviridae family is progressive outer retinal necrosis, which is usually seen in immunocompromised patients, particularly when CD4 count is less than 50. There is no vitritis or minimal vitritis in these patients, hence because they are immunocompromised, and the lesions typically involves the posterior pole. They are multiple, multifocal, deep, dense necrotic lesions involving the major vascular arcade, giving a typical cracked mud appearance, and the prognosis is really very poor despite using 2 antiviral drugs simultaneously apart from heart because of the retinal and optic atrophy. CMV retinitis is again an entity which is seen in immunocompromised patients, and again the CD4 count is less than 50, and CMV retinitis manifests in 3 ways. The classical one is fulminant hemorrhagic necrotizing retinitis, which presents with massive hemorrhage and exudation around the major vascular arcade, giving its pizza pie appearance. The other one is a granular form, which is usually seen in the periphery. There is lesser retinal edema, necrosis, and the most fulminant form is perivascular CMV, which presents and looks like frosted branch angiitis. The treatment is in the form of intravenous ganciclovir, 5 milligram per kilogram body weight, TID for 3 weeks, followed by OD for unless the immune recovery is there. You can also go ahead with the oral valganciclovir, 900 milligram BD for 3 weeks, followed by 900 milligram OD daily until the immune recovery is there. Sometimes you will have to give them lifelong. Dengue is a disease which is very much endemic in India, and dengue affects eyes also. The disease affection is usually bilateral, but most of the time this is asymmetrical presentation. The most common presentation of dengue is subconjunctival hemorrhage,
Your time is-
but the
Can continue.
most, just summing up, but the most characteristic feature of dengue is foveolitis, and maculopathy is more commonly seen with serotype 1. Role of steroids is always doubtful. Chikungunya can present during illness or resolution, and it mimics herpetic retinopathy. Anterior uveitis can be non-granulomatous or granulomatous, and retinitis is usually accompanied by vitritis, and steroids is the mainstay of the treatments. So the take-home message is uveitis is not idiopathic or autoimmune only. Detailed history and meticulous systemic as well as ophthalmic evaluation is the key to clinch the diagnosis. These are my acknowledgements, my sincere acknowledgements to my mentor, Dr. Jyotirmay Vishwas, Sudha Ganesh, and Dr. Sudarshan, and my student and a very good friend, Shivangi, and Mr. Saurabh, who has provided me all the images of my patients. Thank you so much.
Thank you so much, Dr. Tomar. It's a very good presentation. I have just one query from my side, actually.
Yeah.
Do you advise AC-TAP only in posterior uveitis or only in anterior uveitis?
No, if it is a posterior uveitis, depending upon the severity, suppose if I am seeing that amount of vitritis is much more, or it is a pan-uveitis, if anterior chamber reaction is there, then I think it is advisable to go with the AC tap. But if the reaction is only in the vitreous, I think the vitreous tap or vitreous BAPS is important.
Yes. Only in anterior uveitis do you ever advise AC-TAP?
AC tap actually whenever I have severe dilemmas. Otherwise,
Posterior segment is not involved at all.
posterior segment is not involved, and I am suspecting that either it's a masquerade. Like one kid I have seen who was having hypopia and uveitis, and I was thinking that it is maybe because of HLA-B27, but all the investigation came negative and the patient was not responding. At that time I did a AC tap and I sent that to my mentor, Dr. JB, and what he told me that it was an 8-year-old kid, and what sir told me that actually it was a case of retinoblastoma. So in masquerades where I am suspecting that or something, when the patient is not responding to the treatment at that time, routinely I don't prefer to do AC tap.
So a younger child, actually B-scan is more helpful if we are thinking
No,
of
if I am
a
able to see the
masquerade.
fundus, then I am not going to do, because if retinoblastoma is there, you are able to see the fundus, you can get that lesion. But sometimes the media is so much heavy, the vitreous seeding is there, you are not able to look beyond that. At that time I think you should do a AC tap.
Okay.
It is always helpful.
Can I ask one doubt?
Ah.
So, sir, is there any role for this prophylactic acyclovir? Suppose the patient is getting recurrent anterior viral keratitis. Any role?
I
for
think
how
if a
long?
patient is having recurrences of that viral anterior uveitis, I think it is better to give that maintenance dose of oral acyclovir or valacyclovir for at least 6 months.
6 months.
At least 6 months you should give. If it is coming again and again, that valacyclovir is a safer drug. You will have to give that 1 gram OD.
Yes.
And suppose he is having open angle glaucoma, is there any contraindication for starting prostaglandin analogs?
I am having my glaucoma friends, they say that this is not going to affect.
Exactly.
Recently, I am having one patient who is having that serpiginous choroiditis, and that girl was given that posterior septum and tricot, but she was a steroid responder, so the pressures were very high. So initially, I was thinking that should I go ahead, ask my friend to go for the trap, but he said, no, we will manage this with AGM, and we put that girl on latanoprost along with that dorzolamide, and it responded nicely.
Thank you, sir.
Okay, thank you.
Thank you, Doctor. Our next presenter is Dr. Ankur Singh. Dr. Ankur Singh is here. Dr. Ankur Singh. He will talk on case chronicles tubercular posterior uveitis unraveled.
Very good morning to you all on the Monday morning. So, I'm Dr. Ankur. I'm going to talk about
You are
posterior
second author
tubercular
for Wayne.
uveitis case chronicle. So,
You
my
will
talk is
talk
going to
on
be
which,
more about
thing.
cases.
Yeah, you can.
And thank you,
Just
AIOS,
wait.
for giving me
Just
this
wait.
wonderful opportunity.
Yes.
So, as we all know by now, the trabecular uveitis is a form of extrapulmonary TB
I'll write
associated
down
with significant
I
morbidity.
got this name.
There are two possible pathophysiological mechanisms by which we acquire ocular TB. One is
Write down
the
this
active hematogenous spread, that is choroidal granuloma. Second is delayed type of hypersensitivity seen as serpiginous choroiditis. Posterior uveitis per se can be solitary tubercle, merely choroidal tubercles, choroidal tuberculomas with or without subretinal abscess, serpiginous like choroiditis, and trabecular retinal vasculitis. So now comes the diagnosis. Diagnosis of TBU is challenging. Why? Because it's difficult to demonstrate acid-fast bacilli on spears or histopathology or intraocular specimen. So you would be surprised to know till now we just have very few studies which have isolated TB bacilli from the eyes having any kind of trabecular posterior uveitis. Molecular diagnostic techniques like PCR are very good, but they still have a low sensitivity because there is a low bacterial load in patient of trabecular uveitis. So we are left with immunological tests which are quantiferon TB gold or commonly called as IGRA. So what I would like to say is the diagnosis of trabecular uveitis is mainly presumptive based on the ocular signs consistent with trabecular uveitis. So there have been different treatment guidelines. We have course guidelines, we have index TB guidelines. And what do they say? They say that if the patient has serpiginous choroiditis, you have either of the immunological tests positive or radiological test positive, or you have any microbiological evidence, you can start an ATT. So these are the guidelines when to start ATT because ATT has its own problems. In patients with trabecular granulomas, the both immunological and one radiological evidence has to be positive. Why? Because granuloma is usually associated with an active trabecular bacilli. In active retinal vasculitis, if immunological test, that is Mantoux or TB gold, and one radiological test is positive, you can start a patient with ATT. And at the same time, if the patient who you find this test positive and does not have an active retinal vasculitis, don't treat it with ATT. Panuveitis, if again immunological with radiological test positive, start ATT. With the help with the ATT, you should always start with steroids because it can lead to worsening of the trabecular uveitis in few of the patients. So this is one case example of trabecular serpiginous choroiditis. You can see a peripapillary region. We did an FFA in this patient. What do you find? That there was this inferior active area circled in blue. So these are hypofluorescent in the beginning. They tend to leak in the late phase. One other very good investigations to look at the patient of serpiginous choroiditis is autofluorescence. So if you have a stippled autofluorescence or in complete autofluorescence, you are looking at an active lesion. So when this goes down and it becomes completely hypoautofluorescence, this is the time you must understand that the lesion has healed and you can stop the treatment. This is another patient that came to us. If you can see, there are few active lesions, there are few healing lesions. This is how it happens in serpiginous choroiditis. The inferior ones are active. And at the same time, there's a spot in the fovea which is also active. So we thought of, instead of giving systemic steroid, we thought of giving this patient an intravitreal Ozurdex. And he responded very well. So from the vision 6/12, when we thought he will not gain much of the vision, looking at the picture profile of the retina, he gained 6/9 vision. So Ozurdex with ATT, because he was Mantoux positive on quantiferon TB gold, as well as CECT chest positive. Then there is another patient who was again Mantoux positive, quantiferon TB gold positive, chest X-ray was negative. So if you see, he have an active edge which is fovea threatening. So when it was fovea threatening, we had to deal it in very aggressive way. So we gave the patient IV methylprednisolone. But you see, even after 3 doses, the patient did not respond to the IV methylpred, which ideally should. So we thought of adding one more agent, intravitreal methotrexate, in this patient. So this was IV methylpred, 5 doses with MTX, intravitreal, and followed up on the oral steroids with ATT. He responded very well, and you see in the last picture, the lesions are pretty well healed. Now this is a different entity. A patient came to us with this inflammatory BRVO with vasculitis. He was Mantoux positive, quantiferon TB gold positive, X-ray chest positive. In fact, bronchoalveolar lavage that were done in this patient also turned out to be positive for TB. So we started this patient on ATT. We gave this patient an anti-VEGF as well as steroids. He responded very well. We did the scatter laser in the areas which were non-perfusion areas, because we know by now that trabecular uveitis is an occlusive kind of vasculitis. So we treated this patient. We were pretty happy. He was doing well. He has 6/9 vision. And mind it, this is only a one-eyed patient. He came to us later on, lost to follow-up with this vitreous hemorrhage. So one take-home message from vasculitis, trabecular vasculitis, is that these patients tend to develop collaterals less. And when you treat them initially, you have those BRVOs and you tend to miss upon the CNP areas. And these are the patients which tend to go and develop NVDs and vitreous hemorrhage. So you need to follow up the patient regularly. When do an repeated FFA after some time, do an accentuated laser, and the patient tends to do absolutely fine. He is a 6/9 vision and he's following well. All the anti-VEGF that is coming is taken care of. In fact, these kind of patient you can also take upon FFA on the optos, because you also need to treat those peripheral lesions if you cannot identify them clinically. See, trabecular posterior uveitis have sequelae, and this is a patient who came to us on the follow-up which developed a CNVM. We did an FFA, we did an OCT angio. You can clearly delineate this CNVM complex. We gave this patient anti-VEGF only, because he was already treated. He had healed lesions. So he responded very well to anti-VEGFs, and he's doing pretty well. Now this is one case I want to put to the house. You see these orangish lesions. As we have grown up, we have realized that those few orangish lesions are, we think of sarcoid. When you look at the choroidal granulomas, which are of trabecular etiology, they usually are whitish. So orangish means sarcoid, whitish means TB. At the same time, you can see this kind of retinitis kind of picture with an obliterative vasculitis. So we were quite confused, because now we did an investigation in this patient. The Mantoux came out to be 18/18. Not too big, not too high. Quantiferon TB gall positive. History of TB contact. Normal ACE levels. And CCT and X-ray chest not conclusive of TB or sarcoid. So because as per the guidelines, if you are thinking of an choroidal granuloma, if you see on the OCT picture 948 microns, this is a granuloma over here. Because we didn't have the evidence of TB to start ATT, we have not yet started this patient of ATT. We just treated this patient of steroids, and he's doing pretty well. And we have taken care of the CNP areas with the laser. So at the end, I just would like to say is that 90% of the patient of ocular TB do not have systemic evidence of TB. Posterior uveitis is the most common anatomic location for ocular TB. Serpiginous like choroidal is the most common phenotype of choroidal TB. Most common cause of occlusive retinal vasculitis in our country is TB. CT scans are more effective in detecting the healed and old pulmonary lesion than the X-rays, especially the HR cut CTs. Steroid is usually given in a tapering dose for 6 to 12 weeks, and a watch on systemic side effect of ATT should be kept while giving ATT. Thank you very much for the patient hearing. I thank my teachers who have helped me to become what I am today. Thank you.
Thank you, Dr. Ankur. Just one point, like ATT, you yourself advise or you take help of a pulmonologist?
Ma'am, now what happens is, how do we practice in Delhi and how we used to practice in PGI is a bit different previously when I was there. So it's always advisable to take the help of an internist.
Yes.
And we still, in Delhi also, we never start the ATT from our side. The dot center that starts the ATT. Yes. Now, what comes to the prescription? So we always send it to the pulmonologist. In certain cases, when pulmonologists are dicey, because they feel that they leave it to us. The file comes back. They say,
exactly.
if you have a strong clinical suspicion, then you can start the ATT. That is where these guidelines come into play. Now we have index TB guidelines and we have course guidelines. So the last case which I showed you was again this dilemma. As per the guidelines, there was no indication. As per the guidelines, there was no indication of TB.
Because so pulmonologists, they don't start with only Mantoux or TB
yeah,
gold
absolutely,
positive.
That's what I'm saying.
They want always some chest finding or some frank finding in favor of TB.
This is how they are trained to look at the patients.
Exactly.
We are trained to look at the ocular features.
Our direct involvement is needed for them to start ATT.
So you should always prefer to start with the help of an internist who could be a physician or a pulmonologist. But
Yeah.
if you don't get an, your patient, you are worried about the patient, you have the guidelines to support your claim.
Yeah. Okay. Any other questions?
So ESR, ESR per se is a very, vague indicator. It can be raised in so many. A patient of anemia can have a raised ESR. CRP maybe, but then CRP does not have a direct role in, tuberculosis. Because as I said that most of the cases might just have no systemic evidence of the TB, just the ocular. And ocular TB per se is not going to raise the CRP that much. On the other side, when you're looking at those AION patients with giant cell arteritis, you tend to have a CRP high. So they can be values which are slightly higher, but then treatment based on CRP, no. Treatment based on your presumptive diagnosis, the investigations, and the, these immunological tests.
Okay. Thank you, Dr. Ankur.
Thank you.
So we'll go. You have one question. Okay.
So I get your question. So what happened is I'm just going to share a case which was just anterior uveitis, which came out to be positive for trabecular etiology. So I've rarely encountered these kind of cases, but then I have seen in my previous institute that this patient was given a ATT, repeat ATT, because after one ATT there was a remission of the disease and this. But at the same time, when you are looking at this patient, you should also look at that, is this an MDR patient? So if they are MDR patient, you need to titrate your drugs. So this is where the pulmonology is absolutely required.
Okay,
Don't-
we'll actually,
Yeah, thank you.
we'll sort of time. So other speakers have to get enough time. We can discuss off the stage. Okay, and now can I request Dr. Atul Verma? He will speak on posterior uveitis, a case-based approach for diagnosis and management from a UK hospital uveitis service.
Good morning, everyone, and thank you AIOS for giving me the opportunity. So I'm just going to share what we do in the uveitis clinic. I don't have any financial disclosure related to this talk. As we know, posterior uveitis is inflammation of the choroid and the retina. It could be infectious and non-infectious, and that's a really important point, which Dr. Singh also reiterated. But it can lead to significant visual loss. The incidence in the UK is around 1.25 patients per 10,000. And it's normally a disease of the working age group. So that's why it's really important to catch these patients early and treat them. They present most commonly with blurred vision, floaters, and the most common signs are either choroidal infiltrates or vitreous cells. But one of the main things always to do is, beside examination, is take a detailed history, because a lot of time you will get the diagnosis from the history itself. You don't even have to go for any examinations. And then if you have to do examination, a multimodal examination is important. As we know, these are the common causes of infectious and non-infectious uveitis. I think some of them already been discussed. The main thing is, when we are seeing any patient with uveitis, what are our goals? First, it is reduce inflammation, treat the underlying cause, and then preserve vision. And the medication which we use are corticosteroids in various forms, immunosuppressants, and anti-infective agents. But there are other treatments also there, which are like intravitreal injection, Ozurdex, or any intravitreal steroids, or any antivirals, laser therapy, and vitrectomy sometimes. So whenever you see a patient of posterior uveitis, the most important thing is to rule out infection. This is really the most. If you delay the treatment in an inflammatory uveitis by a day or even a week, it will not have that major detriment effect. But if you treat with steroid in a patient with infective uveitis, you will cause a disaster for this patient. So that's one of the most important things. And treatment depends on whether one eye or both eyes are involved. If both eyes are involved, then normally oral medications are better. If one eye is involved, you can give local injections or Ozurdex or something. So let's go with the cases. This 26-year-old Caucasian female presented to us with floaters and flashes. Optician had seen the patient and referred for epiretinal membrane and bilateral blurred optic disc margin. Visual acuity was 6.6, but there was 1+ inflammation of the vitreous with slight blurring of disc margin. And because of that, we also requested for MRI brain, but there was no other positive medical history. So these are the optos pictures, as you can see. I don't know whether it's visible, but you can see some lesions which are radiating from the optic disc in the right eye and also in the left eye. And then these are the OCT maculas at baseline, and I don't know whether you can see some of the inflammation in the vitreous in the OCT. That's the OCT of the optic disc in the right eye, which shows some like disc swelling in the left eye. So what are the differential diagnoses? It could be birdshot, which because of the lesion which are radiating from the optic disc, multifocal choroiditis, panuveitis, mutes, MP, sarcoid, syphilis, tuberculosis is a differential diagnosis in every posterior uveitis case and primary CNS lymphoma. So we got all the investigation, all the immunological markers, viral syphilis test, and HLA-A29, all came back negative except the HLA-A29, which was positive. But we need to remember that 9 to 10% of the patients in a normal population also have HLA-A29 positive. And we had also requested for an MRI with a venogram with that. So we requested an FFA. So that's the fundus image on the 25th January 24 on the left eye. And then there's a multicolor picture from the Heidelberg. And then as you see the FFA, there's a vasculitis, but it's involving both arteries and the vein, and that's the left eye, similar picture. So we started the patient on oral steroid, and that's the other thing which is really important. If you have to start steroid, start on the high dose. Don't start on homeopathic doses like 50 milligram, 20 milligram. That will do more harm than benefit. So always start on 75, 60 milligram, like 1 to 1.5 milligram per kg body weight, and then reduce it down slowly. But because this was looked like birdshot, so we referred her for the immunosuppression also to the immunosuppression clinic, because when you start tapering the steroid and when we came down to 10 milligram, they used to have a flare up. And that's the later on picture for OC. Second picture, second patient, a 32-year-old female, presented with floaters in both eyes, and then saying that it's just like a static on the TV where she gets a bit of glare with some anterior uveitis. And so we requested. But when on further questioning in the history, she did give a history of recurrent mouth ulcers and genital ulcers. So that's the early phase FFA, and you can see retinal vasculitis both in the both the eyes, which increases. So as the history was suggestive of Behçet's, so we started the patient on oral steroids. But then these patients would not just be on oral steroids, so they will need immunosuppression also. So as soon as we started to taper, as you can see, the disease is still not under control. So even with oral steroid, the disease is not under control. You can still see a lot of inflammation, and that's an optos fluorescein angiogram. And then when so we started referred, and then we started on azathioprine also. And as you increase the dose of therapy, you reduce the dose of steroid, so that you come to for long-term immunosuppression. But in between, she had a flare-up, so then we gave her a pulse steroid 500 milligram for 5 days also to help us to control the disease. And this is the most recent FFA. As you can say, still the disease is better, but still not fully under control. So that's why they might have to go on to biologicals or anything. Another patient, 42-year-old Asian male, presented with blurred vision, previously had some eye problem. These are the optos picture. You can see a scar with some active lesion just below it, and which is very well documented on the autofluorescence picture. Left eye is fine. And then basically if we do a fluorescein, that lower area stains quite heavily. So this is active toxoplasmosis. Started on just like Septin type of tablets, and after a few days started on steroids also. We continued for 4 weeks, and patient responded. But as you know, the reason for posterior uveitis, and it can be a cause, so that's why you should always rule those out. And these are the only indications where we should treat ocular toxoplasmosis. If the macula is being threatened, if the disc is being threatened, any major blood vessels is being threatened, or pregnancy, monocular state, immunocompromised state, or anything. And that's where you can give any of the medication.
Please wind up first, Dr. Verma.
Okay.
We are time off.
So I will leave this picture. So this is a patient of 67-year-old Caucasian male who presented with sore, painful red eye, who had a lot of synechial rubeosis. We did all the tests. He did not give any positive history also. So optos pictures did not show. There's a lot of inflammation in the retina. And so ARN and all of that were done. So we did a tap and gave an intravitreal foscarnet at the same time at the tap. But we sent for PCR, but his syphilis triple pallidum came back positive. and then we refer to the GM disease also. And they all need MRI of the brain because they do have CNS syphilis also. I've got a number of other cases, but I'll just skip some of those. So this patient is again like tubercular uveitis, where you can develop peripheral NVE with a lot of retinal ischemia. And this is just one more patient which I wanted to discuss. This patient presented with a patient of temporal arteritis, a 78-year-old female with these lesions, and then you can see obliterative vasculitis. So these patients are where you need to do an urgent tab. So we did an urgent vitreous tab within an hour, gave her intravitreal phoscarnate, sent for PCR, came back positive for VZV, started on valacyclovir.
You can go to your last slide, please.
Yeah. So. So my take-home message is rule out infection, even if it means delaying the steroid or immunosuppression. Don't be afraid of doing a vitreous or aqueous tab, because that will give you the diagnosis. And especially if you consider infections, it's always urgent to do a vitreous tab or an aqueous tab and give phoscarnate or oral antiviral. It will not do any harm to the patient in the short term, but if it's a viral pathology, it will really save their vision. And take a detailed history. And don't assume things because of age or race. Syphilis and tuberculosis can present. Even syphilis I've seen in patients of 75, 80-year-old old patients also. And then always beware of red flags, which are first episode of uveitis in elderly patients, significant systemic illness, immunocompromised patient, and high-risk behavior, and hospitalized patients. Thank you.
Thank you. Thank you. How common is syphilitic uveitis in your clinical practice?
It's on the increase, I think, worldwide. The syphilitic uveitis is on the increase worldwide.
India
so that's
also,
why,
we are
and
seeing
it's
more,
one of the greatest masqueraders. So you should always test. So any patient with posterior uveitis, we test all of them for syphilis. The only problem is for sometimes with HIV, you can't test for HIV without their consent. So if they don't give consent, then you can get a CD4 count. That will give you the diagnosis sometimes.
Okay.
So suppose we are planning for surgery, cataract surgery in toxo case, is there any role for prophylactic treatment?
No, there's no
Is there
role.
any chance of flaring up of uveitis?
No, there's no chance of flaring up. And I said even if there's a flare-up of uveitis, there are only those specific indications where that a disc, macula, or a major blood vessel is threatened, or it's only eye, then only you give treatment. Otherwise, even if you don't give treatment, they will resolve in 4 to 6 weeks' time, most of these patients.
Thank you, sir.
Okay. Thank you. Thank you.
Next, we have
Dr. Pooja Bansal. Dr. Pooja Bansal. She is not here. Then next is Sai Bhakti Sukla. She will speak on use of steroids in ocular inflammation. Better safe than sorry.
So, my name is Dr. Sai Bhakti. I am from Narayan Netralaya, Bangalore. I will be presenting on use of steroids in ocular inflammation, better safe than sorry. So, most of the times, many people feel that it's just uveitis and we can treat with steroids, topical, oral, and sometimes they go on to give even depot steroids. So, I just wanted to discuss a few cases on this topic. My first patient is a 43-year-old female. She is a dentist working in United States. She was a known case of rheumatoid arthritis and had a history of necrotizing scleritis. And she had a long history where she kept visiting multiple, premier institutes included. And her scleritis was not coming under control. At the time of presentation, she was on ATT and on steroids 40 milligrams oral. She had received a posterior subtenon injection. Previously, she was also treated with biologics including infliximab and adalimumab. She was referred to us by the rheumatologist to rule out secondary infection post-immunosuppression, as her MRI scan had showed some granulomatous lesions in the retina and choroid. So this is the old record that she was carrying with herself. So these were the peripheral ulcerative keratitis lesions in the right eye and the area of scleral melt. In the left eye, there was active scleritis and a nodular scleritis lesion in the inferotemporal quadrant. She also showed us images of when that melt had increased and she had undergone a scleral patch graft, which was followed by a posterior subtenon injection, which only led to worsening with scleral melt of the graft and uveal show. Also, there is development of posterior subcapsular cataract, worsening her visual acuity. So at presentation, she had this picture where, as we can see, there is active scleritis in both the eyes. Fundus examination revealed a large supranasal choroidal detachment with pigmentary changes and a nodular posterior scleritis with some subretinal fluid around the lesion. Similarly, in the left eye, there was an active lesion with suspected choroidal granulomas as well, and there was a lot of fluid at the macula. She did undergo AC-TAP previously also, which was negative for mycobacteria, eubacterial genomes and panfungal genome. Her QTB was negative. Even though she was on ATT, her lesions kept increasing. So she was referred to a chest physician to rule out multi-drug resistant tuberculosis, and he started her on levofloxacin. In view of accentuated immunosuppression, we also started her on voriconazole and valacyclovir to be on the safe side, and her immunosuppressive drug was changed to a Janus kinase inhibitor. She underwent a repeat patch graft in the right eye and received an intravitreal ranibizumab injection for the left eye to resolve the macula and improve her vision for the go. She returned to US and we could not have a long-term follow-up with her, and she was, multiple places she was going and taking her treatment. Nevertheless, she shared her images. And we could see that there was shrinkage of the lesions, and her visual acuity was also improving. So basically from this case, I wanted to just highlight the point that it's always better to avoid depot steroid injections in patients with necrotizing scleritis and receiving multiple immunosuppressive treatment when they are prone to systemic infections. We may not be able to identify their markers, even serological markers may come down-regulated in them. My second case is a 59-year-old female patient. This is a case of actually a diabetic macular edema, and we can see these findings on OCT which suggest an inflammatory etiology of the macular edema, and hence in recent use they have also started giving intravitreal steroids for the macular edema. But 2 weeks later, this patient presented to us with acute retinal necrosis. We can see these the periarteritis lesions at the macula, and also the large confluent whitish lesions suggestive of necrosis, and PCR came positive for VZV. These are the OCT findings where the macular edema is still there, and there is necrotic lesions with hyperreflectivity of all the layers in the periphery through the lesions. The patient gave history of chickenpox, and so this was a case of acute retinal necrosis secondary to VZV reactivation in the eye, and the patient was treated with a few doses of ganciclovir injection and followed up with valacyclovir. The lesions healed but with necrosed retina. So always check for a history of viral infections before giving depot injections to patients, and there is a risk of viral reactivation. So not every time that we will be able to know, but least that we can do is keep them on regular follow-up and advise that if you have floaters, redness, diminution of vision, do report as quickly as possible so that we can minimize the area affected. Next comes the Ozurdex, and Ozurdex itself is a very good treatment modality in many, many ways. There are some technical difficulties, and this is a picture of a fractured Ozurdex. Nevertheless, it worked. And the intralenticular Ozurdex, which is the biggest fear of any new person trying to give an Ozurdex injection. Okay, so with that, I'll go to the 60-year-old male patient who had a history of traumatic retinal detachment with IL subluxation. He underwent surgery, but with all this trauma and post-operative inflammation, he kept developing cystoid macular edema. He had received bevacizumab and IVT injections, but still he had persistent edema. So this time, we decided to go ahead with the Ozurdex injection. But the patient came back after 1 month with smoky vision and seeing a line moving in front of the eye, and it was actually that the Ozurdex had migrated into the anterior chamber. On initial examination, the optometrist who had seen the slit lamp had noted it as a hypopion. So, yeah, so this Ozurdex implant may mimic an hypopion. We need to do proper examination. And yes, the patient was being posted for surgery. We started the, the treatment of the corneal edema and the inflammation which was there, but before we could do the surgery, the implant had again, migrated back into the vitreous cavity, and there was no recurrence of anterior migration again. Nevertheless, it is always a learning that we need to be aware that this can happen and watch out. This is one patient with, this is a different patient actually. This is a patient with iris coloboma with an intraocular lens, and we need to also make sure.
How many more slides there, Dr. Sukla?
Pardon?
Your time is
Okay,
off
so
a
ma'am,
long
so
time, yeah.
dexamethasone implants, we need to be aware that we should avoid them in cases of posterior capsular openings, zonular dehiscence, aphakia, and iris coloboma. At least we can just remember these couple of points. And last case is a patient of topical steroid use. This patient was previously diagnosed with Posner-Schultzman syndrome and again visited many places over the years where patient kept having recurrences of raised intraocular pressure treated with topical steroids. She would improve. But then at one point of time when she came to us, we decided to repeat the AC tap, which was still negative. But by use of confocal microscopy, which we do use in our center, we suspected etiology of virus and we treated her with viral acyclovir. And here we can see that from initial stage, when we see her records, she had multiple recurrences of raised intraocular pressure, but just with clinical suspicion, if you can start the patient with antiviral therapy, you can reduce the recurrences of inflammation. Yeah. So just the take-home points that we should have cautious use of deposteroids in patients on immunosuppressive therapy, patients with past history of viral infections, patients with SFIOL, aphakia, zonular dehiscence, and iris coloboma. Also avoid them if you don't know what the exact etiology of inflammation is, and very high index of suspicion for viral etiology for recurrent hypertensive uveitis. Thank you. Yeah.
Thank you, Dr. Bhakti. One thing, actually, in some cases you gave intravitreal tricot and in some cases you gave intravitreal Ozurdex. How do you decide for that? To whom you will give tricot and triamcinolone acetate intravitreal, or to whom you will give Ozurdex implant?
Okay, so I think I would think of three conditions. Initially, the economic constraints in our population where even if I think the patient would need a Ozurdex but can't afford, then I would still go for an IVTA. IVTA is much shorter lasting than Ozurdex.
Yeah, that
so
is more important is duration of action.
Yes,
Then
ma'am.
only
So,
comes
yes.
the
So
economic
if I
part.
feel the patient is unilateral and will need a long-term immunosuppression, so Ozurdex will counsel. And also
Yes.
Ozurdex has lesser chance of raised intraocular pressure. So sometimes we take a clearance from the glaucoma and go ahead with Ozurdex rather than IVTA.
Okay, okay. Any other questions for her? Anyone wants? No questions? Okay. Okay, thank you, Dr. Bhakti.
Thank you, ma'am.
So our next speaker, Dr. Pradeep Kumar, is absent. On his behalf, Dr. Vipin Rana will speak. Topic is combined intravitreal dexamethasone implant and surgery in uveitis. Dr. Suvina Narang is not there, I think.
Morning, everyone. I shall be speaking on Dr. Pradeep. So the talk is combined intravitreal dexamethasone implant and surgery in uveitis. No financial disclosures. Differences in vitrectomized eye. We all know that in vitrectomized eyes there is faster dissolution of the hemorrhage oblique the implants, and there is a shorter half-life for the solutions, and there is a lesser requirement of anti-VEGF and anti-inflammatory actions. So indications for the steroids in DME surgery as of now are pre-operatively as a measure to reduce vascularity, intraoperatively to prevent PVR, and post-operatively to manage post-operative CME. So what we knew till now is that deposteroid have been used at the end of the vitrectomy surgery to control inflammation and reduce post-operative complications like macular edema. And conventionally, steroid preparation is left under gas oblique silicone oil in the form of triamcinolone crystals. And there is no specific dose of triamcinolone has been described in the literatures. So what we wanted to know was to fill this existing lacunae in our knowledge regarding efficacy and safety of using FDA-approved preparations like Ozurdex compared to triamcinolone in uveitis cases undergoing vitrectomy surgery. So the background confidence for using Ozurdex was from these things that the using Ozurdex pre-PPV in cases of retinal vasculitis, which we use usually within a week to decrease the vascularization, and the injected Ozurdex at the end of the ERM in most non-idiopathic etiologies after clearing vitreous hemorrhage in RVOs, a swollen macula was dealt using Ozurdex, and post-vitrectomy long-term anti-inflammatory action. So this is a video where we can see the combined reg RD, and this surgery is being done. So this segmentation and delimitation is done, and so in such kind of cases we need to use the steroids at the end of the surgery for decreasing the inflammation. So what prompts us to use steroids at the end of surgery? And what do we do is that at the end of the surgery, when air is inside at the end of the fluid air exchange, so this globe is insufflated through this infusion cannula, and we inject the Ozurdex from the one of the cannulas. If this is a 23 gauge, we'll take out the 23 gauge port, and from there only we will inject the Ozurdex and leave it as such. There is no need of suturing even in those cases. So suturing was required in 1 cases out of the 51 cases. So the correct method of placing Ozurdex, so this is the correct method of placing Ozurdex post PPV. You just take out this. This is a similar video and go inside. So the only thing is that it has to be under the insufflation. It is not to be done after taking out the infusion port. So it was a retrospective comparative study, and there were 2 groups. So group 1 consisted of 51 patients and the group 2 40 patients. Group 1 Ozurdex was implanted, and group 2 the triamcinolone was left inside. All patients underwent careful clinical evaluation, including general systemic ophthalmic examinations, and the required investigations were done. So this is an inferior placement of implant. What is important to know is that once you place the Ozurdex, if you do not rotate the eye, you keep the eye like this only, and you implant the Ozurdex. Okay, so at times it may go and sit on the fovea. And once it goes and sit on the fovea, it remains like there only, and it sticks to the retina. Wherever it goes, it will stick to the retina, and the patient will keep complaining of the central floater. So what you have to do is you have to rotate the eye inferiorly and then inject the Ozurdex, pointing that Ozurdex also inferiorly. So out of the total of 91 patients who underwent pars plana vitrectomy, they were studied. BCVA was fared much better with the Ozurdex implant. CMT was significantly lesser with Ozurdex implant, and need for injection for the macular edema. So significantly lesser with the Ozurdex implant. There was a requirement of topical NSAIDs, which was significantly lesser with the Ozurdex implant. Floaters, the complaints of floater was significantly lesser in the Ozurdex implant. What we see is that in the triamcinolone group, those particles, they keep on moving inside the vitreous cavity, and the patient keeps on complaining of the floaters. So that is, once it goes inferiorly and sits there, so patient is very comfortable and there is no complaints of the floaters. So the CMT reduction was statistically significant in both the groups at all observation points compared to the baseline. Group 1 performed better at the end of the 36 weeks in terms of BCVA. There was a statistically significant difference in need for topical steroids and patients' complaints of floaters between the 2 groups. Ocular hypertension requiring topical hypotensis was seen in 7 cases in Group 1 and in 12 cases in the Group 2. And 1 case in Group 1 required wound suturing. So to conclude, Ozurdex implant is safe at the end of pars plana vitrectomy in uveitis patients. It gives additional advantages of long-term CME and prevention, CME prevention and BCVA gains, and the single floater of Ozurdex is much better tolerated than multiple floaters of triamcinolone. Thank you so much.
Thank you. You are perfectly in time.
Thank you.
One doubt of mine, actually after doing vitrectomy, you told that you are putting that Ozurdex implant inferiorly so that it will not float, but it is replaced with aqueous only, no? It always floats even into vitreous.
Ma'am, actually, I am from ex-PGI and sir is from AIMS. So they are doing it in the AIMS, Dr. Vinod Kumar. Okay. So their technique is, what they do is, like at the end of the surgery, this is only under fluid air exchange. Under fluid air exchange, he'll take out one port of the left hand will be taken out, and the port of the right hand, he'll take out that, and through that, they will give the injection Ozurdex, and that this infusion cannula will be in situ. Okay. Now, what they do is that gas, so the gas injection is done after that. So in cases, so they inject pure gas. In case of C3F8, they inject 1.2, and in case of SF6, they inject 2 ml. And the air which is there inside, it automatically comes out this port through which the Ozurdex is given.
Okay, that means that gas keeps this under pressure. And
yes, ma'am. So the gas will keep under pressure.
Okay. Okay. And if we explain also, counsel the patient also, they tolerate that implant floater. like they are educated that yes, I will see something in
Yes.
front of my.
Nee, so inferiorly, when they say that inferiorly, there is not much complaint of the flow test.
yeah.
If you do not rotate the eye, keep it straight, and then inject it, then it may sit on the
Definitely.
fovea and it may stick to the retina.
Okay. Thank you so much. Any other? Yeah.
Yeah, silicone oil also they're trying. Actually, I'll come back to you. I'll talk to the main surgeon actually, the one who is doing it. Okay, but this technique which was gas, I'm very much sure of this. Silicone oil I need
That
to
is
ask
for
you
the
once.
gas only. With silicone oil filling, it
silicone
will
oil
float,
also-
definitely.
They are injecting under silicone oil also. They are injecting under silicone oil also. Sure. Thank you so much.
Thank you. Thank you all the speakers. All are too good, but we could not allow you, some of you, to go through all the slides because of the time constraint. So thank you all. We can have a group photograph with all the speakers. Please come to the front.